Good evening, everyone. We're so happy to have you join us on this lovely, warm spring day. My name is Deborah Zimmer, and I am honored to be the president of Temple Emanu-el in San Jose. We are very honored to welcome you to this discussion, including scientists, volunteers, and specialists from the Cancer Center at UC San Francisco. This will be a very important discussion, and it's so nice to see such a wide range of people from I don't even know how far away. It's now my honor to introduce the president of our Temple Sisterhood, Beverly Mendel.
Good afternoon, everyone. I'm Beverly Mendel, Sisterhood President at Temple Emanu-el. We're proud to be sponsoring this program for you today. Sydney Peterzak, who is the program manager at the Center for BRCA Research, and myself have been working on this program for many months, and it's great to finally see it become a reality. I also want to acknowledge Oliver Hausman, marketing coordinator at Temple Emanu-el, who worked very hard on this as well. Thank you both very much. Now I'd like to tell you a little about our very special speaker today, Dr. Pamela Munster. She is a professor of medicine at the University of California, San Francisco, where at the Helen Diller Family Comprehensive Cancer Center, she is leader on the Experimental Therapeutics Program, Director of Early Phase Clinical Trials Unit, and co-director at the UCSF Center for BRCA Research. In Dr. Munster's lab, UCSF scientists are exploring new ways to detect, surveil, intercept, and cure BRCA-related cancers. In addition to her laboratory research, she develops novel strategies to treat patients with incurable cancers as an oncologist. Dr. Munster serves on multiple local, national, and international committees focused on developing new treatments for cancer, has published over 200 articles, authored textbooks, and is a frequent lecturer. A native of Switzerland, she leads breast cancer awareness campaigns in the United States, United Arab Emirates, and India. Dr. Munster was diagnosed with the BRCA2 mutation in 2012. There was not an easy place to coordinate her care, and so she set out to create the UCSF Center for BRCA Research in partnership with Dr. Alan Ashworth. By transcending the doctor-patient perspective, Dr. Munster gives a framework for successful treatment, epitomizing the personal patient-centered care that is hallmark of the UCSF Medical Center. Dr. Munster recently authored a book called Twisting Fate about her experience as an oncologist and a cancer patient. And now I'm honored to introduce Dr. Pamela Munster.
Hello, everybody, and thank you so much for this kind introduction. It's very wonderful to be here, and I know it would be a lot nicer to do this in person. However, given the circumstances, this is probably the next second best, and I think it may give people an opportunity who may otherwise not be able to travel. This being said, before we talk a little bit about the program on BRCA, I was asked to give a little bit of an update on COVID. And as you know, like many of us who either deal with cancer patients or people who have risk for cancer who need screening, there's a lot of uncertainties. Can we go to the hospital? Is it safe to go outside? And can we resume our screening and treatment protocols? So to give you a little bit of an update in numbers and what's going on in the world with COVID, we have just under 4 million cases now confirmed. There's about 270,000 deaths. The US has the highest number of cases and deaths. in the Bay Area, we have been quite fortunate, and in San Francisco, we actually had created a specific clinic for COVID patients that many of us volunteered, including me, and we really had the fortunate decision this week that we can actually close this clinic because we didn't have enough cases. So the social distancing and the staying at home had really made a difference for us. So in terms of the where do we go and who's at risk and who should stay home longer and should be particularly careful is, as you know, the major risk is age. Being over 70 puts people at a much higher chance of dying from COVID, not a higher chance of getting it. Anyone can get it, but the higher chance of dying from it when you get COVID. Other risk factors are diabetes, hypertension, and cardiovascular disease. Surprisingly, it is not as clearly linked to people with lung disease. People with lung disease don't have as much a chance of dying. And patients with cancers are not necessarily at higher risk. So for our cancer patients in the Bay Area, we've actually continued to treat our patients. We have continued to give chemotherapy and all other therapies that are important. We encourage folks to come back in and really be treated, and with the entire hospital, every staff member, every patient wearing a mask and having proper protection, the risk of getting COVID in the hospital is actually fairly low. There's a lot of effort on currently finding treatments for COVID. These include antivirals. There's the first antiviral that has been now being used routinely. That's called remdesivir. It's an IV drug that people get when they get to the hospital. There's a huge effort on vaccines. Hydroxychloroquine has not been as promising, and a lot of what's coming out in the media and from our administration probably should be fact-checked by scientists. But that being said, though, is like for most of us at risk for cancer still poses a much bigger risk for dying than COVID. So we really feel very strongly that you should not leave out the possibility that you need to continue with your screening and awareness for cancer. We have a very intense research endeavor to find out who is at risk for cancer, because a lot of our screening modalities don't work so well. But if we knew that someone carries a BRCA mutation that puts them at much higher risk for cancer, we would actually have a much more intensive screening program. Then we wouldn't start screening at age 50 with a mammogram. We would actually start screening at age 25 if a girl has a BRCA1 or 2 mutation. We probably would not do a mammogram, we would do an MRI. So knowing whether someone has a genetic mutation makes a big difference. And so part of our program today is also talking about genetic testing, risk assessment, who should be tested, who should we start thinking about, could they be at risk, could they be at higher risk? How we want to help you a little bit, how to look at your family history and see whether this is a family history that puts you at higher risk for cancer. And with this, I actually like to hand this over to Julie Mak, who is a genetic counselor who specializes and has focused her life on really figuring out, like, how do we detect people having higher risk? And if we have a person who is found to have a mutation, what does that person need to do and to prevent cancer? And just take this up front for a moment. Having a genetic mutation is not finding cancer early. Having a genetic mutation tells us that someone is at risk. Julie, may I take it may I hand it over to you?
Thanks so much. And I just want to echo what everyone has been saying. Thank you to Beverly and Deborah for welcoming us and helping us set up this event. And I think a lot of us are experiencing similar emotions to what Dr. Munster mentioned. In many ways, this is such a strange time to be getting together, and yet it's just all the more important. And I've been reflecting and preparing to talk to you tonight how, I go back and forth between not being able to think 2 days ahead of what am I going to be doing on Saturday to like furiously cleaning my house and being really productive. And so I think this is a nice way for us to have an opportunity to talk to you about something that we can do while we're at home to plan for the future and look forward to the future and take care of our health. So I really appreciate the time tonight. As Dr. Munster mentioned, this is something that she and I have been working together for many, many years, and really excited to share what we have. As a genetic counselor, it's one of those jobs that, when you meet somebody at a party, they don't know what you are doing at all, or they imagine something really strange. But I like to say that it is really a job that has to do with genetics, but also counseling and talking to people. And so I'm just going to take a few minutes to give some background information about things that you've heard little bits and pieces about. You've heard gene, you've heard BRCA, you've heard mutation, you've heard cancer. And I'm sure that I will say some things that people do already know, but I do always like to just start from the beginning to make sure that we're using a common language and thinking about this in a common way. So I will just start off, as I said, we were talking about genetic risk for cancer. People can get cancer for lots of different reasons, and actually most cancers are not caused by things that run through the family. Most cancers are caused by the natural process of aging, maybe things that people are exposed to during their life. So that's how most cancers are caused, but we are here to talk about cancers that are caused by things that run through the family. As Dr. Munster mentioned, there can be clues. So how do we distinguish between cancers that are due to age and cancers that are due to genetics? Family history is one of those tools. It's not a perfect tool by any means. There's people who don't know as much about their family. There are families that are very small. But that is one of the things that we mention is how do we know cancer might be genetic is if we see a lot of people in one family who are getting cancers, especially if they're getting the same kind of cancer. So 3 women with breast cancer, or 3 men and women with colon cancer in a family. So it's the number of people who are getting cancer. It's also the ages. So I mentioned that age is one of the most common reasons people get cancer. So if we see a young person, like a woman who develops breast cancer at 35 or a man who develops colon cancer at 35, again, we are thinking that can't just, it doesn't make sense to say that that's caused by age. Maybe there's another cause. So when we talk about genetic risk for cancer, Dr. Munster already alluded to this. It's genetic risk for cancer. So none of the tests that we're going to be talking about here tonight have the goal of telling somebody they have cancer or not. They have actually a loftier goal of telling people maybe you are in a high risk group and maybe we can take steps and interventions, which again, Dr. Munster started to mention, and we'll pass it back to her to go into more detail. To try and catch those cancers early or prevent them altogether. So as I said, this is a very forward-looking kind of project that we're here to talk about. And as I said, it's nice for me to have an opportunity to talk about it at a time where it's hard to think 2 days ahead. It's really nice to be thinking about what we could do to prevent cancers down the road. So again, I promised to talk a little bit to clarify some of the terms that we've been throwing around. You all cast your memories back to high school biology class. Each human being here inherits a set of genes from their mother and a set of genes from their father. And each of those genes is an instruction for something. And when we're, at dinner parties, when we were at dinner parties, those were the days. We like to talk about things that we can see, like, oh, I got, this crazy hair from my mom, or I got, I'm really tall because of my dad. But there are lots of genes that work on the inside of our bodies. And the genes that we've been talking about, the one that we're going to focus on tonight, the BRCA1 and BRCA2 genes, or they're also called the BRCA1 and BRCA2 genes, are genes that work on the inside, and the job that they normally do in our body is actually to help repair things. So they have a job of protecting us from getting cancer. So these are good genes to have, and we all have them, and we all get a BRCA1 gene from our mom and a BRCA1 gene from our dad, and a BRCA 2 gene from our mom and a BRCA2 gene from our dad. And as I said, they're in our bodies helping repair things all the time. We know in those families I was mentioning where we might see lots of people with cancer, or we might see very young people with cancer, or we might see a rare cancer like a male breast cancer, a man with breast cancer. We know that in some of those families, the cause is that one of these really important genes, BRCA1 or BRCA2, or one of the many other genes that we know of, that's supposed to be repairing things and protecting you from getting cancer, isn't working properly. And you heard Dr. Munster use the term mutation, which is the way that we often refer to a gene that isn't working properly. So having a BRCA1 mutation means that you've inherited a gene that isn't doing its job. And as Dr. Munster said, that doesn't automatically give you cancer, because you will have that other BRCA1 gene from your other parent that's still there. You'll have BRCA2. You have all these other genes, which Marta will mention as well a little bit later, my colleague Marta Sabbadini. So we know that having a mutation in one of these genes, as we said, doesn't automatically give somebody cancer, but it does make them more vulnerable because they have one less repair mechanism than the average person. And using that knowledge, as Dr. Munster mentioned, we can try to catch cancer earlier for these people. We can even take steps to prevent cancer. And why are we here to talk about all of this in this setting? I mentioned family history as being one of the clues that tells us which families are more likely to have a BRCA mutation than others. One of the other things we know is that BRCA mutations can be found anywhere in the world, in any population in the world, but they are more common in certain populations, including Iceland, French Canadians, and also people of European Jewish ancestry, which again is sort of what brings us to this particular community, because we know that 1 in 40 people of European Jewish ancestry, or what's sometimes called Ashkenazi Jewish ancestry, has a BRCA1 or BRCA2 mutation. Some of those people will have clues from their family history. Other people won't have clues from their family history, again, because they have a small family, because it's a family with a lot of men, so we aren't seeing all the breast and ovarian cancer. Maybe it's a family where people don't talk about disease, or people died young for other reasons. So we're here to share a little bit more information about BRCA mutations, particularly the fact that we see them more in the Jewish population, and what we can do with that information. As a well aware, talking about cancer and being at high risk for cancer isn't something that everybody thinks is something they want to hear or want to learn about. But I think there's so much we can do with that information that we wanted to make sure we brought that to you. And that's where I'd like to pass things back to Dr. Munster to tell us a little bit more about how this information is being used for cancer treatment, for what kind of science and research she's been doing in her lab and our colleagues at UCSF have been doing to turn this information about being at high risk into a tool that people can really use. So we are here to just share this information. And for those of you who might test positive through UCSF and the project we're talking about tonight, or already know that you're positive or know a family member, we have a wonderful team there with Dr. Munster, Marta, my colleague, I, Dr. Dewan, another oncologist. We have a nurse practitioner. We have a psychologist, nutritionist. We just have a really comprehensive program to help support people should they find out that they need that. So I'd like to pass it back to Dr. Munster just to share some more about what the latest is with people who are BRCA positive and how we're using that information and what we're learning.
Thank you, Julie. That's been very helpful. Whenever I give a talk, people have a tendency, I'm a little bit too professorial, and I tend to talk over people's heads. And most people now ask me, like, why can't you tell us a story? And I now have a story to tell, my own family story. And so I think it's a story that's really illustrate how knowing about my genetic mutation made a big difference. So I was a breast cancer oncologist for many years, and of course I never really thought that breast cancer would find me, because I thought when you're an oncologist with this specialty in breast cancer, why should you get breast cancer? And of course, like the question would be rather like, why wouldn't you? So I was 48, I had this premonition, or otherwise called a gut feeling, that I needed a mammogram. And I had a mammogram and I had a lot of abnormalities, and then it turned out that I had a very early form of cancer, actually stage 0 cancer. But when I looked at my pathology under the microscope with our pathologist, we both felt this looks like more like a BRCA mutation, and so I had BRCA testing. And I remember the genetic counselors, like very rightly so, said like, but you really don't have a lot of family history, and there's not very classic family story for a BRCA mutation. And so my father had no siblings, and my mom had a lot of relatives, but no one really had any breast cancer. And so I had BRCA testing anyway, and long and behold, I was found to have a BRCA2 mutation. Now, how did this impact my treatment? Knowing that I had a BRCA2 mutation, I actually didn't just do a treatment for the breast cancer I had. I also wanted to make a bigger approach to like prevent other cancers that I could have. If you have a BRCA2 mutation, you actually have a very high chance to have other cancers in the same breast or in other breast over the next 10 years. So the risk was very high. So I ended up with a bilateral mastectomy, because someone with a BRCA2 mutation probably also has about 20% chance of having ovarian cancer by the time they turn 70, and my chance of surviving, if I actually stop my crazy mountain biking, is fairly high. So I also had my ovaries removed, as something we would do when someone has a BRCA1 or 2 mutation or other mutations. But then where the BRCA mutation really came in very importantly was when a year later my father presented with an upset stomach, and he was at that time 78. And in a 78-year-old, the upset stomach is actually quite, it's not that uncommon, right? So he saw his doctor, because we knew that the BRCA mutation was from him and not from my mother, but my father also had a BRCA2 mutation. Rather than sending him home with a pat on his back and an antacid, he was actually very quickly screened. He had an MRI, and long and behold, he had a 9-centimeter tumor in his pancreas, at which time it was felt to be unresectable, meaning the tumor could not be removed. And he was pretty much told to put his affairs in order. Now, because he had a BRCA2 mutation, a chemotherapy is actually a bit more effective in someone with pancreatic cancer and a BRCA2 mutation. So he had what we call neoadjuvant chemotherapy, meaning chemotherapy before a possible surgery. So he had surgery, and then he had chemotherapy, and by 3 weeks, his chemotherapy shrunk his tumor by half, and then he had surgery. And pancreatic cancer, typically the life expectancy is about a year, maybe 18 months, a little bit longer. My father was lucky enough. He lived almost 6 years with his pancreatic cancer and died of something else actually last May. So was with us for a very long time with a very high quality of life and only intermittent treatment for his pancreatic cancer. And I think this speaks to the fact that how relevant it is to have a different approach for someone who has a BRCA mutation. And we also know now that there's specific drugs called the PARP inhibitors that exploit the vulnerabilities that tumors have who have BRCA mutations. And then, the BRCA2 mutation in our family, also my brother has a BRCA2 mutation, so he's now getting intensively screened for pancreatic cancer and prostate cancer, as am I. So hopefully this is really impacting us directly, and it will impact my children. If they have a BRCA mutation, we will not test them before they're 25, and all my children are under 25. It may actually guide their treatment and prevention decisions in a very different way. So and before I hand this over to Marta to talk a little bit more, is like I want to speak a little bit to the possible good things that could happen if you actually know your genetics. Like when I see a patient who had breast cancer at 35 or 45 and is very young with breast cancer and they have children, they always ask me like, what's the risk for my daughter? And I think if someone has a BRCA mutation and someone has a known mutation, we know where the cancer is coming from. The daughter will then have a 50-50 chance of carrying this gene. If the daughter does not carry this gene, then her risk for breast cancer, ovarian cancer, and other cancers is actually quite low. And if she does have the mutation, we actually know what the risk is and we can start the screening very early. So it has very clear guidance on what we do with our younger generation. And again, but I really like to really make it very clear, we don't like to check children before they're 25. And I also feel very strongly that the young adults should make their own decision. While it's, of course, I want to know whether my daughter is positive or not, but I do think ultimately she should decide herself whether she wants to be tested or not. And I think this is, in a nutshell, hopefully explaining you a little bit of what we're doing research-wise. We're developing new drug, we're developing new treatment strategies, we're looking at different ways of preventing cancer with local therapy. That's not just everyone has to have a mastectomy. We're also trying to find out what are environmental factors that people can actually influence. We have a large program that's about to start to trying to figure out, does exercise, sleep, vaccines or others impact the likelihood that someone with a mutation actually has cancer. And I think we're happy to take questions later, but at this point I'd like to hand the baton over to Marta, who is talking a little bit more about our FACT study and why we think genetic counseling and genetic testing in the broader population would be a good thing. Marta?
Thank you, Dr. Munster. Thank you so much for the overview so far, and I'm glad I can talk a little bit more about genetic testing. So far, we've, Julie and Dr. Munster have spent our time telling us how do we identify the people and why it is important. What can we do once we have this information? But then the question comes down to, how do we test people? Sometimes people do want genetic testing, but they don't really even know where to start. So, well, the traditional way for genetic testing was that someone would go to their doctor, they would be identified to be at higher risk, they would be referred to a genetic counselor who talked through sort of like the things we've talked about so far, and then help someone decide if genetic testing is the right thing for them. And while this is still an approach that we favor and we think like it's very effective, we've also over the years started realizing that we are missing still a large part of the population. There are individuals that are either not flagged by their providers, where insurance doesn't cover testing, or just as Julie was saying, sometimes the family history is not obvious, or other reason why these people might not be suggested that maybe they should go and talk to genetics. Now, we do know, as we said before, that there are certain populations where the probability of having a BRCA1 or BRCA2 mutation is higher, like the Ashkenazi Jewish population. So we started wondering, maybe we should have a broader approach, a population screening that would allow for us to identify more people and be proactive instead of having to wait for the first person in a family to be diagnosed with cancer. So we currently have a study with UCSF that is called the FACT study. You might have heard or you might have seen flyers about that. And this is a study that is ongoing, and COVID or no COVID, we are able to continue. We are enrolling patients, and we're always happy to have people contact us about this or enroll in the study. And this is a study that is for population health and cancer testing. And basically the way it works is someone is eligible for the study, can call our center, they sort of like fill the questionnaire, enroll, sign a consent, and then they're provided with a saliva kit that can be done at home. So you might be mailed a kit to your home, and then you can just spit in the tube, send it back to the lab, and somewhere around 6 weeks later, you'll get results of genetic testing. Now, one of the interesting things about the study, or one of the things I would like to sort of like highlight, is also the fact that while our event today is really focusing on BRCA1 and 2 because are the ones that are the most relevant for the Ashkenazi Jewish population. The testing that is done through the FACT study is actually a multi-gene panel that includes 30 different genes, 2 of them being the BRCA1 and 2, but 28 more that increase the risk of developing cancer throughout one's lifetime. And we do this because we've started learning more and more. And if we're trying to figure out, well, do I have an increased risk for cancer? Why don't we just go and try to see if there's something else as we're doing that? As I said, in 6 weeks, you can get results through the studies. And the results kind of come in 2 ways. They can come directly to the portal where you get the report and you can read it. Or sometimes you get contacted by the genetic counselor or me and Julie because we want to discuss these results with you. One of the things I would like to stress about this, being the person who normally has to do this contact, is that the fact that we want to talk to a person who is in the FACT study does not mean that they have a BRCA1 or 2 mutation. Just means that maybe sometimes these results are a little more complicated. They need a few follow-up questions. They might have something we want to discuss with you and explain in more detail. So please, if you participate in the study and you hear from us, don't be frightened. We are there to help you just understand the test results. This testing, very importantly, I would like to mention that I forgot before, it is free, and as I said, is available. We'll have the information available to all of you. One of the things is like this, as I said, this is not a traditional way of doing the study, and therefore we have a questionnaire because we really want to hear from you how your experience was with the study if you participate. We want to know, is this a good alternative way? Is this something good? And how was it for you? So we can always think about it and improve what we do. So if you're interested in participating in the study, there's an email that we will post at the end, but it's fact_study@ucsf.edu, or there's a phone number, 415-476-2415, where you can ask questions and have more information about that. In the chat, you have actually the information about the FACT study. So they are going to be there, but please feel free to let us know if there's other way for us to pass it on to you, or if you have more questions about the study. I think this is sort of like a quick overview of what we can do and what we've been thinking about offering. And again, I don't ever want to stop saying that we really want to hear from you and your experience. So please reach out to us and let us know. So I think at this point, I'd like to introduce our next speaker. Her name is Lindsay Kimmel, and she's a BRCA advocate, a volunteer, and a patient herself. She was lucky she's here to share her experience with us from a patient perspective. And Lindsay, please go ahead.
Hi, everyone, and thank you so much for having me. So I am 33 years old, and I was diagnosed in 2018 with a salivary gland cancer. It's a rare cancer up in your jaw. I'm a nurse, and I didn't even know. It's actually in my parotid gland, and I didn't even know where that was. So I did go through surgery, and because of where it was located, they had to cut my right facial nerve. So I do have partial paralysis on the right side of my face. So if I'm not fully smiling, it's not because I'm not really happy to be here. It's just because I can't fully move that side of my face. So since then, the cancer has spread, and I am a stage 4. And the good news is, and Pamela mentioned it earlier, that because of my BRCA status, I have been able to try different off-label treatments that actually do respond specifically to the BRCA mutation. So I am on a PARP inhibitor along with an immunotherapy, and that's kept the cancer at bay for about 8 months now. So yeah, I want to talk about being a cancer patient and a BRCA carrier. And one important piece is something that Pam also mentioned prior, which is it allows not only me to be educated about you know, my status and my health, but also my family members. My dad found out that he was a BRCA carrier through my testing, actually. The other thing that I was able to do was, because I was only 31 years old when I was diagnosed, I went through IVF before my first round of chemotherapy, and I made embryos with my husband, and we were able to actually screen the embryos and take out the embryos that had the BRCA mutation. Now, that's obviously an ethical and personal decision, but it was something that I was able to do knowing my status. I have a long family history of cancer on my father's side. Both of my paternal grandparents died young of cancer, along with all of their siblings, actually, and it was primarily ovarian and breast cancer. I'm also an Ashkenazi Jew, and I'm a nurse. So I kind of put that all together and knew that it was important that I got tested. I decided to do it at age 29, and I found out I was a BRCA1 carrier. I did it through UCSF, and I received incredible care. I had an amazing genetic counselor that sat down with me and talked through everything multiple times and on phone calls. And I was given at that time the recommendation to do, again, it was just a recommendation and I could make my own personal decision, but they did recommend doing a double mastectomy and removing my ovaries after having children. And that was my plan. I was also being monitored with breast MRIs and mammograms staggered every 6 months, as well as pelvic ultrasounds. The difference between my particular cases, I didn't actually end up getting breast or ovarian cancer. It is a gland, but it happens to be in my face. So I did do everything that I was told, and I still ended up developing cancer. And I think one of the things that I've already talked about is knowing that you are a carrier actually allows you to pay more attention to your own health as a patient and advocate for yourself. So I started developing pain on the right side of my face, and I went to the doctor. I was being treated at Kaiser, where I am a nurse, and I was turned away 6 times. They kept saying, "You're young, you're healthy, you know, get a night guard." And I did all of those things. It wasn't until I went back and demanded that I get an ultrasound and I see someone else that they did the biopsy, and, you know, the rest is history. But I really learned that it's not just, first of all, it's not just screening, but it's also being aware of your body and being aware of what this means for you. So I don't want to say all of this to scare anyone. I think I was thinking about how to prepare for this, and I was like, what would I have wanted to hear having been on the other side of this? And it really is that you are your own advocate for your care. Getting your, knowing your family history or getting yourself tested really sets you up for early detection, screening, monitoring, and education. And I think it's the best thing that you can do for yourself to empower yourself and go from there. So I think that's it, and we can take it back to Julie, and I can answer any questions at the end too.
Thanks so much, Lindsay. I really appreciate it. I think, it's just really powerful to hear your story and appreciate you. I think it speaks to why we're all here. Why do we, in the middle of a global pandemic, want to take the time to talk about genetic risk? Is, as you said, it's an opportunity to take charge of your health. And as I said, to me, it's a very forward-looking step. I'm glad you mentioned our team at UCSF. As I said, we are here to help people if they want before testing and certainly after testing. And Marta mentioned that we do have this study, the FACT study, as a way to make testing more easily accessible, especially during a pandemic. So I just really want to thank all of the panelists and Lindsay for sharing your story and just, I think, conveying the passion that you have for advocacy. People use that term advocate lightly, and that I think that your advocacy really comes through here. There are some questions coming through that Marta's been looking at. She did mention that the FACT contact information has been posted in the chat for Zoom. Sydney put that up. Thank you, Sydney. But I will pass it back to Marta, who's going to just sort of look at the questions and see if we're able to answer some of those tonight or look into them further for you.
Thank you, Julie. So yes, we have a few questions, and I'll just start with I have a question from a 72-year-old man who's Jewish and has a 33-year-old daughter who was recently found to have a BRCA2 mutation and is under close care right now. But this gentleman, his mother had breast cancer and lung cancer, and he's wondering if he should get tested for the mutation as well. So Julie, do you want to answer this?
Sure. Thanks, Marta. I'm really glad you asked, because I think when we talk about breast cancer and ovarian cancer, so much of the focus is on women and the women's side of the family. And we know from this question, but also from Dr. Munster and also from Lindsay, that these genetic mutations can come from the mother's side or the father's side. And so I don't know just from this story whether the person who's asking the question will test positive, but I do definitely recommend getting testing for parents whenever we find this, because it did come from one of the parents. Men can get cancer. Again, we heard Dr. Munster speak about her father who had pancreatic cancer, and how, as much as it's very hard to get that diagnosis, having the information about the genetic risk really made a difference in his care and his survival. So I do recommend it both for men themselves, but also because it helps us figure out, which set of aunts and uncles and cousins and other people we should be reaching out to. So Marta knows this is a lot of what we do is talking to people about how to share that information with the family. We have a lot of tools to help with that. So yes, I definitely do recommend testing in this scenario. And I think it highlights the importance for men as well as for women.
And I think I want to take this a little bit further, because for you, the person asking the question, we probably want to look at your prostate a little bit more closely. And we want to also make sure, like as in the case of my father, whether we should or shouldn't do any screening for pancreatic cancers. I mean, we have a bit more guidelines on this. So we actually really built our hereditary cancer clinic for exactly people like you. So you can go to a place where we can answer those questions. Should you get tested? And if you test negative, then it's more likely that the mutation comes from the mom of your daughter. And if it's if you have it, then this really, as Julie said, it may impact sisters you may have, or your sisters and your brother's children, who then also should be tested. So I think this has actually quite significant implication. And I think we would be very remiss if we didn't very, very strongly encourage you to come talk to us about testing. Should you get tested? We think yes, but no one should just get tested. Everyone should have an opportunity to sit down with someone and talk about what it means.
Great, thank you, Dr. Munster. I think Lindsay sharing her story has brought a few questions, and I think one of the questions is for Lindsay, which is about how did genetic testing go for you? Did you have the genetic testing before or after your diagnosis of a parotid gland cancer? And they're asking if you can describe how you were able to get tested with such an unusual cancer.
Yeah, I did get tested prior to my diagnosis. It was actually 2 years before. So I was already going through the breast MRIs and mammograms and pelvic ultrasounds. And getting tested was really easy. I went through UCSF, again, like we've discussed, you spit into a tube. You want to make sure it's just yours, not anyone else's. And I got the results back within couple weeks, I was able to talk to one specific genetic counselor that I really was able to develop a relationship with and ask all of the questions. I felt like, you know, I'm a nurse and I'm also someone who needs all of the information to feel okay, and I was really provided with that. So that's how it went. Is there anything else?
Yeah, I might want to add to this, and I think it's really important to stress that, you know, parotid gland cancers are not typically associated with BRCA mutation.
Mm-hmm.
And they don't really have great treatment either.
No.
So having a parotid tumor and a BRCA mutation really gives us a completely different way of treating this cancer.
Yeah. Yeah.
It was very good that you were tested before and that you knew about your BRCA status. And I think we also want to really stress, like, anyone who has a BRCA mutation, or anyone who has maybe not have a mutation, if you find any lumps or bumps or any abnormalities, it's really important to seek out medical attention, not wait 6 months and think, yeah, maybe nothing.
Mm-hmm. I completely agree with that.
Thank you, Dr. Munster. You answer my next question, so I can go on to the next, since people were wondering if parotid gland cancer are normally associated with BRCA mutations. I've seen a few questions about more confidentiality. So one of the questions was, who has access to the genetic test information? So the question is about who prevents insurance to sort of like use this information against you at some point. Julie, do you want to take this one?
Sure. So if you, and we've been talking about different ways that people get tested. So maybe I'll talk a little bit about testing in general and then about the FACT study more specifically.
Thank you. There was another question about the confidentiality of the research, so that's wonderful. Thanks.
So generally speaking, this has changed a lot. I have been a genetic counselor in this area for almost 18 years, and the way that we talk about this and the way that we handle this and think about it is very different than it was when I started my career. Yes, I think that there's a logical concern that says, if I have a test that says that I'm in a high-risk group for cancer, is that bad for me in terms of getting insurance? And I think that's a very rational question. And I will say, you know, I'm neither a fortune teller nor, you know, I can't tell how laws and things will change, but I can, as I said, tell you what has changed in the time that I've been a genetic counselor, all of the things that have been implemented. So this is now treated like many other medical tests. So it is confidential in that, you know, just like you get an x-ray or you find out that you have cancer, that's between you and the doctor and the laboratories that perform the test. So who has this information? Your laboratory, your doctor. Your insurance company doesn't automatically get a copy of their results. But of course, if you test positive, and as we've been saying, you know, we are now recommending a breast MRI for a young woman, for example, it may actually be beneficial to share that information. So it's confidential as much as any other medical information is. Sometimes it's actually useful to share that with your insurance company. In terms of protection from discrimination, which is what I think a lot of people are worried about when they ask about confidentiality, this is what I think is really much better now than it was when we started. So we have the Affordable Care Act, or Obamacare, which we know actually sort of does away with the whole concept of a pre-existing condition, or the idea that you're treated differently based on your medical history. But a lot of people say, well, what if that goes away? Marta and I in our world talk a lot about a different law called GINA, which is not as, you know, doesn't have as catchy a name, that stands for the Genetic Information Non-Discrimination Act. So this is a separate 2008 federal law that prevents health insurance and employment discrimination based on a genetic test result for someone who's otherwise healthy. California has CalGINA, which is an even more robust version of that federal law. So it is confidential within reason, because of course, if we know you're positive, we want to use that information. You are protected, again, within reason, And I think ultimately we can have these conversations with people individually, but we, you know, I don't want to lose sight of, as I said, I can't make a promise that this would never, ever hurt you, but I don't want to lose sight of the value of this information. And when I balance the value of this information, the use of this information against a theoretical risk, which is very protected because of HIPAA and Obamacare and GINA, I would be concerned about somebody shying away from testing just for those concerns. This goes to the other question now. If you do testing the way Lindsay did, or what Marta and I do, you know, every working day, is sitting down with people individually, we can help answer all those questions. We can help tailor exactly how we do it for you. If you do it through the FACT study, again, your confidentiality is the same. The small difference is, well, there's kind of pluses and minuses. So your information is available to UCSF researchers who are bound by all of these same confidentiality rules. So that in some ways it's exposed to a few people it might not otherwise be, but they're very careful. In some ways it's more protected because it's not part of your medical record immediately. You've done it through a research study. We will give the results to you. So in some ways there's a little bit more more, I shouldn't say safeguards because I don't think it's unsafe, but more layers if you do it through the research study. But I think, again, ultimately people are worried about the positive result. Ultimately, the benefits of sharing a positive result with your doctors is, in my mind, greater than hiding it from them. But
Right.
there are many steps. Sorry, that's a long answer, but that's a,
Thanks, Julie. No, I think this is on many people's minds. So it's actually nice to have a nice overview, because sometimes it's even hard to wrap your head around exactly how could this impact you. So it's nice to have someone who can just like take it from different standpoints.
But I also like to mention that, you know, be mindful that you don't put everything on Facebook and social media, because that is, once it's on social media, no longer really belongs to you, right? So insurance companies could theoretically serve the web and look out for you. So we don't think there's any drawbacks, but I think one should be a little bit more careful how open you are with your mutation on social media. Coming from the person who wrote the book about it, right?
Thank you, Dr. Munster. I actually have another question for you. So are there ongoing, so there are studies about ovarian cancer starting in the fallopian tubes, actually. And so the question is about, does removing the fallopian tubes also can help prevent ovarian cancer for younger patients? Do we know? What do we know about this at this point?
So yeah, there's actually, starting off in mice and other laboratory study, we actually found that the initiating events for the ovarian cancer actually starts in the fimbria at the end of the tubes. And then often that's the first step even in humans where the cancer starts. So there has been a lot of studies looking at removing the tubes, and this was actually found in when I was in my younger years. Stephen Neyrod, one of the eminent BRCA scientists, found that people who had tubal ligation, not even tubal removal, actually had a low risk of ovarian cancer. And no one could quite understand what that meant. And I think it turns out now we do tubal removal. There's not been clearly the gold standard of studies. And gold standard of study means like you take a group of people where you remove the tube and you take a group where you don't, and you randomize them, and ideally randomize them to get either procedure or not a procedure, and then 10 years later you see who has more cancer. We don't have those kind of studies, but there's some emerging evidence that removing the tubes really helps. So we actually do this in someone who wants to keep their ovaries, but it's done with childbearing. But none of this is 100% sure how well this works. And we do remove someone's ovaries a little bit depending on their family risk, on our general risk assessment, whether they had their children or not, how well they would tolerate going to menopause at an early age, and how likely we can give them hormone replacement therapy. You're on mute.
Again, sorry, I keep doing that. Thank you so much. That was very helpful. There are a few questions about people who had testing some time ago, and there are some questions about should testing be repeated, and how often should that be done? Is that a good idea? Julie, do you want to give an overview of sort of this idea of what if someone had testing some time ago?
Yes. So what I will say about genetic testing and how it's changed over time, I like how I get the long time or how things have changed over time question, is genetic testing accuracy has been excellent for a really, really long time. So whatever your genetic test results said a long time ago, I generally trust that. But what has changed a lot is how much we test for. So there are things certainly that we test for today that we didn't test for in the past. I think that question is answered very individually by looking at what testing you had done already and what things we were worried about and what the things we would want to look for in your family, which leads me back to the FACT study. So there are, if you go to that website that's listed, or email, if you contact through the email or phone number that's listed, this is testing that we are targeting to certain people. So Dr. Munster mentioned that, if you have for the gentleman whose daughter was BRCA2 positive, that is a scenario where we don't use this study for testing. We feel like this person has a 50% chance or higher of having this mutation. We want to spend a little bit more time in detail about what it means. So there are settings that the study is very appropriate for, other settings where I think a conversation is more appropriate. And I think people who've had prior testing of BRCA1 and 2 are actually excluded from the studies. Somebody has to remind me. Is that correct, Dr. Munster? I'd have to, yes. So if you've had prior testing, yes, it may be appropriate, but it's kind of case by case, and we'd be happy to look at that with you. But it wouldn't be the best way to do it through the study. Also, if someone has a known BRCA mutation in the family, they are excluded. Yes. So similarly, the question that came up earlier, that's not the best application of the study, and it's actually an exclusion of the study from the study.
And since
Marta and Julie, I want to bring in the VUS question here, because I think this is on a lot of people's mind and often don't know how to ask and how to understand what that means. And then it's like, can you speak to the new RNA testing that is now being considered for people with the VUS?
Marta?
Sure. Yeah, so one of the difficulty of the interpretation of genetic test results is that not always the answer we get is clear cut. So what we do in doing genetic testing, we basically, genes are just a sequence of letters, and we read this code and we say, is there the correct letter in there or not? We know that we have differences in our genes, and we know that some differences are absolutely benign. They don't affect how the gene works. Well, we know that sometimes when there's a difference in the gene, that affects the functionality, and that's a mutation, and that's all we've been talking about today. Well, sometimes when we do genetic testing, we end up having a result that is a little bit hard to interpret. We see something different, a different letter, a difference in the code of the gene, but we actually don't know if the functionality is affected or not. This is what's called a VUS, or variant of uncertain significance. And this is something that is not that uncommon at this point in genetic testing, especially if we think about if we test a lot of genes at the same time, we all have slight differences in our genes, so it's not uncommon to get that. Well, while we undergo genetic testing, not always, but in the majority of the cases, these VUSs are reported. And this is the case with the FACT study, for example. So sometimes in these VUSs, in the great majority, end up when we have more information, we know that these are benign findings. Over 90% tend to be what's called reclassified or reinterpreted as benign findings. So in clinical care, we normally treat them as a negative result until we know more. unless there's some evidence from the family or for something else that this is something that could be more significant and more serious. And before, when I was talking about the FACT study, I said, you know, in the majority of the cases, you might have your results released through the portal, and you might see a VUS in the portal. And the reason why it's released and nobody talked to you about is because we don't think this is too significant at the moment, and we don't really have much. We would treat it like a negative result, so we don't want to take the time discussing. However, sometimes we call you if there's a VUS, because maybe it's a VUS that we can be a little bit more, we would like to know more information. Maybe we would like to know more family history. We would like to know, we would like to tell you, we're a little more concerned. So maybe let's stay in touch and let's do something about that. So I think this is one of the hardest part of genetic testing currently, where it's sort of like our technology is moving a little bit faster than our knowledge, and we're trying to sort of like mind this gap with doing that. And this brings in Dr. Munster's second point, which was RNA studies. New genetic testing now, that sort of like the new level of genetic testing has started included what's called RNA study. The RNA is sort of an intermediate from the DNA that is just the instruction to the functional unit that actually does the work that is needed in our body. And we figured out that sometimes once just looking at the DNA, we're not able to recognize if a change we observe in the sequence is important or not. But sometimes if we are able to obtain and create the DNA that is not naturally obtained for that, we might see a difference, and we might be able to have a better interpretation of the original studies. So more labs are trying to put effort towards this new technology. The majority of genetic testing still does not include RNA studies, and RNA studies might be added later. It's something new, it's on the horizon. We will be doing more of that, but is not absolutely needed today to undergo RNA studies. But we might select someone who can benefit for an added on at some point. Julie, do you feel like there's anything to add to, or you have anything else?
No, that's perfect.
All right.
Description of the imperfect situation.
And since before we were talking about the FACT study, I know there were a couple of like questions in the Q&A that I just briefly want to clarify. Someone was asking if you have to be part of UCSF to be part of the FACT study, and thank you for reminding me. I did not mention that you do not have to be a UCSF patient to participate in study. That's not a requirement, so you don't have to. Insurance plan is not involved in the FACT. This is a research. You can just email or call the number. Someone will review your eligibility, and if you are, they'll just send you some form to sign. They review what the consent is, and they will send you a kit at home. So there's nothing else needed, just really you reaching out and contacting us. On the website, you can find the specific of the eligibility. We can send you later, but it's sort of like you have to be English speaking, over 21, reside in one of the counties of the Bay Area, no bone marrow transplant, transfusion, no leukemia, lymphomas or limitation. And of course, if you have one of these things, you're more than welcome to call and present your specific situation, and we can review that. And then I think we've already talked about the family history and the mutations before, but this is sort of an idea of who we're looking for. And of course, at least one of the grandparents has to have Jewish ancestry. Let's see, we still have a little bit of time. I think there was a question about COVID at the beginning. Dr. Munster, I don't know how you feel about this, but someone was asking if you were familiar and if you had thoughts on suppressing TMPRSS with hormone therapy for COVID-19, as apparently there was a recent Italian research study that commented on that.
So this is a good question, whether suppressing TMPRSS can really help with COVID. There is suggestion that TMPRSS mutation can be associated with a higher risk of viral infection, but I think a lot of research is going on, and a lot of it is whether this is true or not related. And this question was from Rick Davis, and I saw that Rick Davis also had a question on somatic versus germline BRCA mutation, and I actually think I would like to take that. I'd take you up on that question, because that's actually a really good question, because on TMPRSS, there's a lot of research going on and we just simply don't know. There's also a suggestion that estrogen helps with COVID, And is it opportunity or serendipity or just chance? It remains to be seen. But does a germline mutation act differently than a somatic mutation? Is actually an important question. And so a germline mutation means the mutation is in every cell in your body and you inherited this. A somatic mutation means it's only in the tumor and the tumor lost the normal function of BRCA. In terms of treatment, if you had a cancer, we think that the difference is probably not that big. And in someone with a somatic BRCA mutation, particularly in prostate cancer or other things, can respond to PARP inhibitors just as well. However, someone with a somatic BRCA mutation will not pass this on. So that's only in the tumor, not in any other cells. It has not, so we don't have to do family testing for that individual. And that's the very different point. And so I think that there's a big difference. And what we're testing is we're looking at germline mutations. We're not looking at tumor mutations.
Thank you. There was also a question about a 65-year-old male who was diagnosed with stage 4 advanced prostate cancer, and after diagnosis had a positive BRCA2 testing. And in addition to Eligard, has been on olaparib for over a year, and the PSA has been undetectable. So the question is like, how long can these drugs, you know, with prostate cancer, we see this sort of like a drug works for a while and then it stops, and it's like, what are we seeing with PARP in terms of like long-term data and effectiveness? And can we switch PARP, or once you've used one, that's sort of like, you've done that kind of course of treatment?
So, you know, not making specific recommendation to the treatment of the person asking. In general, if a cancer therapy works, we usually continue as long as there's no progression of the tumor and as long as the person benefits and doesn't have extensive side effects. Of course, it's very hard to keep someone on chemotherapy for 5 years. And I think part of the advances of drugs like PARP inhibitors that are oral and are giving a little bit of a different dose than we would give a chemotherapy, the advances are that we could theoretically give someone a PARP inhibitor much longer. So in someone in this scenario with a good response, clearly suppressing prostate cancer, not having a lot of toxicity, we probably would keep going. If the tumor starts no longer responding or stops responding to this PARP inhibitor, we sometimes try another PARP inhibitor, but typically that's not indicated because we think they're too similar that we have good evidence that switching one PARP to the other would make a difference. And we typically like to switch up the chemotherapy or the approach to the cancer anyway to give the tumor a different exposure to different set of drugs.
Great, thank you. I know there was just one quick thing I wanted to say. Someone asked $1 million question. If one has the BRCA test, does it cover BRCA1 and 2? What does it exactly mean? Julie, do you want to tell us?
I think it depends on which BRCA test you had. So, I mean, certainly what we're talking about here today and what the standard test would be today would include both genes. But as I said, I think it's really important for us to go back and look at each person's specific report to see what's done, because depending on when it was done and what lab it was done, I've seen such a huge range. And I know we're going to be wrapping up soon. And I just want to mention, we're kind of talking about two different paths here. So for people who never had testing before, don't have a mutation in their family, but are Jewish and want to do this, I think the FACT study is a great route and option for people who have just a lot more questions or very specific questions like this. I have been tested before. etc. We're not excluding you from getting information. We're just saying that it's not appropriate through the study, but Marta and I and our whole team at UCSF is happy to talk to you individually about those kind of unusual situations. So my answer would always be, I would want to see that report to see exactly what was done in the past. But going forward, what we're offering right now is a very comprehensive test.
Marta, you're mute again.
Sorry. Thank you so much, Julie. I think we are at time here, so I'm very happy with all the question and the discussion, and I'll leave it on to Dr. Munster.
Yeah, I think I hope this was helpful, and as I said, we created a program for anyone with a family history of cancer with gene mutation predisposing someone to cancer to come and seek comprehensive guidance, counseling, testing, treatment, so that it's not seems like if you have a BRCA mutation, you have to find your care for the ovarian cancer, you have to find your care for the breast cancer. And really an important part was like what I think we are very proud of. We actually see about a third of, or almost 40% of our patients are men. So we see a lot of patients, and despite the fact that this is a breast and ovarian cancer gene, which is now no longer really clear, but that's how it was first discovered. This has clear implications for men, for family members. We want to bring the family members in to seek questions on like, how do I prevent cancer? Can our family members get tested? Can we do something to not pass this mutation on? And then this study is just another way for people to get tested without having to pay for it and getting comprehensive counseling if they do test positive. And then, of course, I really like to thank everybody. Lindsay, thank you for coming forward and talk about your cancer, particularly pointing out that sometimes BRCA mutations are a cancer enabler, not necessarily a cancer causer. So your mutation probably enabled the product to form a tumor.
Yeah.
And I think highlighting and really telling us like how relevant knowing about your mutation was for your care. And then Deborah, thank you for doing this, and Sydney for the organization. And please, for anyone who I have not mentioned, this has been a lot of behind the scenes effort. I really thank you all. Marta, back to you.
Okay, the last thing we wanted to just remind you is that through these difficult times, we are doing appointments via Zoom. So if anyone has questions, if anyone wants to reach us, if anyone has anything we can do, we are, while going into the medical center is a little hard, we're always available and we'll be happy to do what we can and help you out through all of this.
Thank you all and good night.